Good evening, everybody. Welcome to this very exciting session sponsored by Vascupedia and by Cyber Medical about stop exposing yourself, keeping in line with the new ESVS radiation safety guidelines that are now online and have not yet been published, but they're online for everybody to read them on the ESVS homepage. I'm very honored to be here with two big speakers. We have Professor Morel from Nantes in France, and we have Professor Riambo from Barcelona, Spain, who have a large experience not only with fusion technology, but also with reducing radiation. So it's going to be a very exciting topic. If you have any questions during the talks, please do not hesitate to ask them on the Vascupedia app. I can see them here, and I can put them online on the screen, and we can, if we have enough time, we will definitely be able to discuss them. So let's first start with the first presentation of Professor Riambo. If you would share your screen, and then we're going to dive right into the session.
Thank you. Thank you very much for the introduction. Thank you, Vascupedia and CIDER, for the opportunity. So thank you, CIDER. Thank you, Vascupedia, for this opportunity to talk about radio protection or radiation reduction, because it's part of our job also to be aware about this particular topic, because often, much more often, we are dealing with this particular energy every day, almost every day. It's a good news that European Society of Vascular Surgery take this particular topic in as a guideline in order to collect a lot of recommendations in order to reduce the radiation exposure. For sure, every day we are playing with this particular tool because the endovascular area in our armamentarium represents an important involvement of this particular energy, the X-rays. But everybody knows also that X-ray has some kind of harmful, some kind of consequences in the short, also in the long term, consequences. So for me, it's a good news to recognize that ESVS take this particular topic in as a guideline. There are some different kind of tools in order to minimize our risk of radiation exposure. For sure, you know the ALARA principles, talking about the aprons or any kind of shields, and also the lead glasses, the distance, and also the timing, and the use of zoom or not zoom, and the lateral projections. So, but beyond the ALARA principles, there are a lot of different kind of possibilities to reduce our X-ray exposure. There are some, for sure, new softwares in order to detail our planning with a very nice accuracy in order to plan in beforehand our procedure, and then you can avoid radiation later on during the procedure. Also, you can overlap the images using the fusion image during the procedure. That takes advantage in order to reduce the time exposure about X-ray exposure. For sure, in the future, we can play with another kind of X-ray free navigation tools. Think about FORCE, for instance, the FORCE technology, still now and just in the beginning. And also probably in the future, the robotics can play a role in this particular sense, in this particular direction. I'm talking about corindus, for instance, robotics that allows to the physician to play outside the room. That means far away from the radiation. Let me talk about the planning as well as during the navigation, and also about the follow-ups. So the recommendation 18 in those particular guidelines has this kind of statement: image fusion should be considered during aortic endovascular procedures to reduce radiation exposure. So fusion play a role in order to reduce the radiation exposure. This is a recommendation of class 2A level B. For sure, when you plan in your laptop or in your office using the softwares, you and just making some advantage in order to avoid radiation during the procedure. And also you can overlap your images using the fusion during the navigation tools when you are playing with the different kind of anatomies, especially for a long procedures like fenestrated or even branched devices. And also you can review all the details of your different kind of procedures if you have the opportunity to play with all the registered procedure later on, and just to to be aware about some kind of difficulties and some kind of tricks for the next or for the future procedures. On CIDR plays a role in the plan and in navigation and also in review. And probably in the next, in the next year, we have the opportunity also to play as a surveillance protocol, as a follow-up protocol in order to calculate volumes and diameters automatically, and also to involve the artificial intelligence. The recommendation 17 is a class 1 recommendation. Detailed preoperative procedure planning, including the use of 3D workstation, is recommended to reduce radiation exposure in endovascular procedures, mostly related to the aorta procedures for sure. As you can see here, you can play with different kind of MPR as well as volume rendering images. Also, you calculate the distance, you can calculate also the diameters, all the length, and even the angulations. You can predict the angulation in order to accommodate your C-arm as perpendicular as possible to the target vessels. So even you can have an online collaboration remotely using the phone, or using even the platform, the website, or even the tablet. This kind of automatic segmentation, it could be obtained with regular CTs, even with a poor quality scans, mitigating factors outside the physician control, for example, contrast or poor ejection fraction, obesity, or bone density, etc. So the CIDR software is capable to play with this not so optimal circumstances in terms of a CT image. You can mitigate that particular, limitations of some kind of CTs. For sure, if the CT is quite optimal, the images and the time consuming could be less for your planning. As you mentioned before, you can obtain a remote collaboration using the contact with all the offices in the CIDR office in order to solve any kind of drawback during the segmentation, even during the position of your rings and all the markers. You can put it in your planning. That could be very important in order to plan as accurately as possible beforehand, before the procedure itself. The recommendation 14 is again a class 1. It is recommended that use of digital subtraction and geography by limited to critical step during endovascular procedures, and that is carried out with the shortest time per run, lowest frame rate, and least number of acquisitions possible to acquire inadequate images. So you need to play with digital subtraction with film as less as possible during the procedure. So you have a good planning, and also you can get all good images overlapping with a good fusion. Then you can also avoid a lot of digital subtraction and geography. That is, as is looking in the reality in the clinical case, you can see all the the perimeter of the anatomy, as well as some rings, red rings, in order to mark or more relevant target vessels, the right renal artery, for instance, in this case, and both hypogastric arteries. So that is important to recognize that particular overlapping is automatic on the table, and you don't need to perform any kind of a pre-acquisition on table, just to have the possibility to look for two vertebrae at the level of the lumbar vertebrae, and then the fusion is automatic. As you can see here, even the software can accommodate the orientation or the position of the patient. If you compare on the position of the patient in terms of the vertebral position during the CT, and also the machine or the software can accommodate and can correct the position on table during the procedure. You can get that particular images and fusion, as you can see here, with the frame of the anatomy, as well as the rings. You can put a different kind of markers. All the markers you are needed can put it during the map, procedure beforehand. And you can see here in the right side, the volume rendering, as well as with the ring markers. The software, the CIDR software, also can be adapted or could be adjusted by just a remote control during the procedure, but it's not necessary to move all the anatomy. It's just in the anatomy you are looking for, close to renal arteries. You can modify the position of the rings and adjust your positioning of the angiographic views to the planning or to the map. It just in this particular case, move the number 5. You can adjust the level of the lobus renal artery, just moving up that particular point without more distortioning about the rest of the anatomies. That is important to recognize. That is very useful in order to avoid later on more contrast media or more radiation due to the use of the digital subtraction angiography. Even in this particular extreme case, you can see how the anatomy is corrected or is stiffer due to the fact to put the device inside the anatomy. So the curves are corrected. Now it's more straight than before, and then you can, moving the different points of the anatomy during the procedure, you can adapt your anatomy according to the real position of the aorta, even with the stiffer devices inside the anatomies. The recommendation 26 is a class 3 with a level B. In order to avoid some kind of things, you need to avoid the stem angulation, the lateral views, because then the power you needed from the X-ray machine is so high, and then the radiation is so high too. And this the prolonged use of a step gantry angulation is not recommended during endovascular procedures. So you need to avoid as much as possible the stem angulations or the lateral views. Like for instance, in this particular case, you can see the red rings, and we can play even for the mesenteric arteries and ciliary trunk from the AP projection, because you are confident about the previous mapping and the overlapping, and then you can avoid the the lateral views, just except for the deployment of the stent, the bridge stent, just to be as accurate in terms of the proportion of inside the aorta related to the ring position, to the fenestration position too. So you can play mostly with AP projection and avoid angulated projections during the procedures, even in complex cases like in this example. So in summary, CIDR endovascular maps helps minimizing radiation exposure, because up to 50% overall radiation exposure can be obtained by CIDR. CIDR endovascular map can significantly reduce the number of this digital subtraction angiography runs. CIDR also can significantly reduce radiation exposure to the patient and the operator for the different kind of maneuvers we mentioned before. And the use of CIDR maps has shown to significantly decrease both iodide contrast volume used in patients and the patient radiation exposure via dose area product. So thank you very much for your attention. I'm just open for a few questions you needed to comment on that. Thank you very much for your attention.
I'm very excited about this technology. I mean, I've been using fusion technology since a few years now, first in Münster with Siemens, now with Philips here in Bern. This CIDR technology, it's implementable on every hybrid room, or is it just based on one product?
Yeah, this is a very good question, because it's a very young, technology, but you can implement in any kind of fixed X-ray machine. That means in hybrid rooms as well as in C-arm mobiles. So in C-arms also you can be capable to connect with the CIDR. It's a specific trolley with a big screen, 27 inches screen, and then even you can be in connection with the C-arm in the not so high-tech rooms. Even in these particular circumstances, you can play with that. We have Siemens in both the rooms. We have now another one in another position is a GE, but for all of them we have connection with CIDR, with fixed C-arms, as well as in our C mobile arm is possible to be connected and plays very well.
Okay, so that's a big advantage, I think, yeah, because I mean, at the end, it's going to be also a question of money for a lot of people, and still a lot of us are using just the mobile C-arm. And I think if you have the possibility to have fusion technology there, this would create even less radiation, as you mentioned, for both operator and for patient.
And the screen is even bigger or larger than the regular screens for the mobile C-arms. So
okay, so you get another screen.
Yeah, it's quite big, so you can see more clearly the images, regular images, as well as you can use fusion on the mobile C-arms. That is play a very nice role for those much more modest, ambience. You can use that particular tool and just be approached very close to the hybrid rooms with not so expensive technology.
That's a great remark. Is also on the guidelines they mention that the use of high quality screens, larger screens, are better than using a lot of magnification during your procedure, because there's a large distance between your screen and where you're standing as an operator sometimes. So that's going to be playing an important role as well, I think. You mentioned CIDR support. Does this mean they will help you install all the rings, or how do I have to understand this?
Just if you any kind of drawback you can get during the map, manual over during the work mapping, then you can call them. You can connect by the website, or even by the tablet or even the phone, and automatically they are in touch with you, and they can help anytime, 24 hours. So it's very useful to have this particular help. But this, for sure, when you are much more familiar, you have less questions or less doubts to be solved by the office. But for sure, at the beginning, it could be very helpful for just to be familiar with the software itself.
Okay, perfect. One last question before we go to the other presentation. Can you just quickly explain? Is it it's a 2D, 3D reconstruction with the 3D from the CT scan, or is it just a plain view and it adapts itself automatically?
Is you can get 3D views. You can play with the different planes of the space, and that's very useful for some kind of difficult tortuous anatomies to locate very well the ostium of the target vessels, of the takeoff of the vessels, for sure. And the view is 2D for sure, but during the procedure, the acquisition of the first the two vertebrae of the lumbar vertebra is enough in order to have the overlapping, and that overlapping plays all the time, and is also adapted even during the movement of the table. So if you move the table or move the C-arm, the markers are following your movement. It's quite intuitive, and so for sure is quite safe. But my recommendation is to test before in order to to have the good calibration is just to test with a small shot of the contrast media to locate, for instance, the lobus renal artery, and then you can calibrate the movement, and you can calibrate the position of your rings as accurately as possible.
So the segmentation is just done with an AP view, and it automatically puts in the CT scan. Okay, nice.
Yeah.
And you mentioned that you can move the rings separately. You can adjust also yourself on the table, or do you need an extra person to change the correction, or is it something you can do being sterile at the table?
Could be made by the same operator or any kind of assistant, because it's a small remote control. You can play with the arrows, and you can put inside of a sterilized bag, and you can move the anatomy, not just the rings. Even you can move the different kind of angulations if you need it, and in independent segments of the aura. That means it's not necessary to. There are software that when you move any single positioning, you are moving everything on block. But for a CIDR, you can move segmentally, then the distortion is less, and also the reproduction of the anatomy is much more accurate in this way.
Okay, perfect. I think this is a good transition also to your talk. So now we can have the talk of Professor Morel from Nantes.
Thank you very much for the introduction and for the kind invitation to this exciting webinar. So what do we know today from the literature available on CIDR imaging guidance system? So first of all, we know from this first multi-center observational study of 109 patients included in 2014-2015, that this system is robust, accurate, fast, with a mean time of the overlay displaying on the screen of 8 seconds and usable. And these data have been used for the CE marking. The second paper, published in 2016, was a prospective comparison of accuracy of an image-based tracking system, so the CIDR system, versus a hardware-based tracking system from the hybrid room in 12 patients during complex EVAR. And as you can see on the image, the error magnitude of the placement from the true anatomy during image overlay was less in the CIDR system on the green mask on the right than for the hardware-based tracking system, as you can see with the right rings on the left. This clinical study, published in 2018, is a prospective observational study where we assessed 44 consecutive patients who underwent infrarenal aneurysm repair using the CIDR fusion guidance, and we compare this group to the historical cohort of the 2 previous years, including 32 patients performed without the fusion system. So what we have seen with this study is that over the first 10 cases performed using fusion, we have seen a trend to a reduced number of DSA runs and procedure time, underlying the learning curve associated with the fusion use. Also, we have seen that the DAP and the air karma were significantly higher in the control group as compared to the CIDR fusion group. So of course, the fusion is one of the tools that explain this reduction, but probably not the only one, as this was not the same operator who performed the cases in the historical control and in the fusion group, but still we have seen a huge decrease in exposure parameters. Also, we have seen that the number of DSA was significantly lower in the CIDR group, but the median operation time and the fluoroscopy time, which reflects the complexity of the procedure, were similar in both groups. This is another study published in 2021, which was a pilot prospective study about the fusion use during aortoiliac occlusive disease. It was a pilot study, 1-year inclusion period, and 37 patients with symptomatic orthoiliac lesion were randomized in a SIDAR fusion group or control group performed without fusion. And the result suggests that SIDAR fusion results in reduction in radiation exposure parameters, and the median DAP was 18 for the SIDAR group as compared to 22 for the control group, with no change in procedure time or iodinated contrast. We also worked about the deformation tool. So this paper is a bicentric retrospective cohort of 157 complex and infrarenal EVAR performed using SIDAR guidance and the deformation tool. So the inclusion time was 2019 to 2021. The aim was to assess if the segment tortuosity would predict the real-time deformational movement of the aortic or iliac segment. And what we have seen is that the visceral aortic deformation is consistently superior and anterior, whereas the iliac deformation is highly variable. But the magnitude of intraoperative deformation is not related to preoperative aortoiliac tortuosity. And finally, this last paper, published very recently in September, is a retrospective analysis performed on 53 FIVA performed without fusion and compared with 66 cases using SIDAR fusion guidance. And the author reports that the use of SIDAR guidance resulted in non-significant decreases in mean fluoroscopy time and operative time, a statistically significant decrease in ioninated contrast volume used, and a statistically significant decrease in radiation exposure regarding DAP and cumulative air karma. So now that we went through this literature overview, I'm going to talk about my personal experience of SIDAR and how it helps to reduce radiation exposure in my practice. So in my practice, SIDAR is integrated, used on a large screen in our hybrid room. It's a simple and user-friendly process which allows each vascular surgeon of the team to familiarize themselves with it very quickly and to use it for every patient. So in my team, the radiographer imports the CTA into the SIDAR vaults and creates the map few days before the procedure, and they are helped by the artificial intelligence which identifies the vessel most likely to be relevant to the surgery. Of course, this map can be adjusted, and once satisfied, the radiographer clicks on the location they want to place the rings on the vessel ostia. The rings are automatically placed on the correct angulation, and the map is then ready to be used and saved automatically. The automatic and constant calculation of the position of the arterial tree maintains the accuracy of the fusion mask, even after several table or gantry movements. And the semi-rigid map is accurate once updated for deformation following a contrast injection. And as you can see on this picture, it's quick and easy for the radiographer to update the map for anatomical deformation using the remote control whenever necessary during the procedure. So this is an example of a 4 FIVAR procedure. Usually you don't need to adjust the mask during the embolization of the IMA, for example, or polar renal, as there is no large rigid sheath inserted yet. So as you can see here, the mask is accurate without the need for deformation. And after a short injection, we have managed to embolize the IMA. Then once the stent graft is inserted, we perform a short DSA to see the renals and adjust the mask as explained by Prof. Riambo. Here is the mask before the deformation and after the deformation. And then you can rely on the fusion to open the stent graft and do the target vessel catheterization. You can see both renals here. And now that the 4 vessels are performed, still the rings are in the right position as compared to the fenestrations. And as you can see, most of the time, the fusion is still accurate when you check the internal iliac arteries. So in my experience, SIDAR fusion guidance is very reliable and useful, especially during complex EVARs. So now what about our RadioProtect study? So early in 2022, we have conducted an online national French survey about the radiological equipment of public and private centers in France, and also on the fusion used during infrarenal EVAR and orthoiliac endovascular revascularization. We received 104 answers that say that about the radiological equipment, only 45% of the vascular surgeons who responded to the survey have access to a hybrid room. And within this group, less than 40% have access to the hybrid room daily. About the use of fusion guidance during procedures, less than 30% of the vascular surgeons always use fusion guidance during EVAR, and less than 15%, so very few, of the vascular surgeons use fusion guidance during orthoiliac revascularization. So our study RadioProtect has been granted by the French government. So this will be a French multi-center prospective randomized trials. We expect it to start mid-2023. 7 university hospital centers in France will be involved. They have no access to fusion imaging system. The period of inclusion will be 18 months with 1 month of follow-up only. And the aim will be to assess the medical and economical impact of the use of a mobile hybrid room. This means SIDAR imaging guidance, then plus a flat panel detector plus a floating table during infrarenal EVAR and orthoiliac occlusive procedures as compared to no fusion imaging guidance. So these are the centers that will be involved in the trial. And so we expect to include 350 patients. So for both infrarenal EVAR and orthoiliac procedure, these patients will be randomized after stratification for procedure and task if it's an orthoiliac revascularization. So 175 patients in each group, and we will assess the quality of life, radiation exposure for both patient and medical team, the contrast use, the total operative time, the technical success, and of course the complications. So our central hypothesis with this study is that imaging fusion guidance and artificial intelligence have the potential to be clinically effective and cost-effective by improving outcomes regarding procedural time, potential device positioning errors, and regarding radiation exposure for both patient and staff, as well as nephrotoxic contrast material. If significant outcomes are found, we think that the study will help centers to obtain funding for advanced imaging system equipment and change medical behavior regarding radioprotection. Thank you very much for your attention.
Thank you also for this excellent talk. I'm going to dive in directly into your last message. You expect to have reduction in procedure time and contrast as well. We've seen in all the studies that you mentioned that the radiation dose is reduced, but for EVAR cases, normal EVAR cases, not the procedure time and contrast meaning. How do you think we can change this in the future, also with fusion technology? Is it because there's a learning curve, or is it because people are still a little bit afraid to trust the fusion technology? What do you think?
Yeah, exactly. I think there's a learning curve, and as explained by Friambo, if we use a fusion properly, we will decrease the number of DSA of check, so it will decrease automatically the contrast volume and probably the total operative time. But I agree with you, it's hard to have significant results. But we think that if we perform a good education of the surgeon on how to use the fusion properly, we should obtain a reduction in iodinated contrast volume and total operative time.
I've seen in your fenestrated case, I didn't see any DSA. Are you still using DSA, or are you just using contrast medium under fluoroscopy?
So I use DSA once the stent graft is inserted, before opening the stent graft when I perform the deformation, and then to check that I'm in the right target vessel, I use only fluoro loops. Yes, no more DSA.
Okay, so almost no DSAs anymore with the fusion technology. What about the learning curve? Because you mentioned also in one of your papers, I think, that the first 10 EVAR cases, we didn't see a lot of impact because of the learning curve. What do you think, how many cases, how many normal EVAR cases should one do before really getting to know and how to use the fusion technology?
So in the paper I performed with Tara Mastracci, we've seen that over the 10 first cases, there's a decrease in radiation and an improve of how the surgeon use the fusion, but then it's done. So we need, I think, probably less than 10 cases to know how to use fusion.
Do you think there's a need for practicing this technology outside of the OR room on some kind of model? Is this a possibility?
Probably, if feasible. And also the plan is to set a short video to explain the surgeon how to use a fusion properly and how to rely on fusion guidance.
Okay, and you mentioned in your which was very I think less than 40% of vascular surgeons performing EVAR cases did not have a hybrid room. Vincent also already reported that this technology can be implemented also on the mobile C-arm, but still less than 30% are using fusion technology. Is this because they don't have the fusion technology available yet? Or is this because, I mean, they think they don't need it for a rather, let's say, normal EVAR case?
Yeah, for normal EVAR cases, among the answer we had, it was because the fusion was not available. This is a little bit different when we talk about orthoiliac occlusive disease. Probably more surgeons think that it's not useful for occlusive disease. But for infrarenal cases, they don't use fusion guidance because they don't have it.
Does the CIDR technology also can be implemented for peripheral cases or only aortic cases?
Well, it doesn't work on the lower limbs. So because you need to see on the screen 2 vertebrae. So you can use it for orthoiliac occlusive disease, but you cannot use it, at least for now, for infrainguinal occlusive disease.
And why do you think the French doctors don't believe it will work in ortho-occlusive disease? Did they tell you that was this also answered in the questionnaire or was not asked?
It was not in the questionnaire.
Okay.
But well, it's.
How does the deformation tool work? It's you just click on adapt to the fluoroscopy image, or does it can adapt itself just based on the stiff wire or on the endograft that is in place, or how does it work, the deformation tool?
So the deformation tool works as a with the remote control. I think Prof. Yambo explained that. And you can adjust only the segment of the aorta that you want to well, improve
Modify.
yeah, yes, to modify, and you can adjust, of course, the other part of the aorta if you want, but most of the time we only adjust the target part of the aorta.
Okay, maybe a question for the both of you. Where do you think are still disadvantages from this technology, or where do you think it needs improvement or can use improvement?
I believe that the CIDR software is on progress, is on work in progress. I is totally excited about the incorporation of the artificial intelligence. That means incorporate a lot of big data collection, and then you can even predict much better which kind of patient could benefit the best from some specific even devices or different techniques, fenestrated achiever, for instance, or another kind of devices, especially when we incorporate also the follow-up of the surveillance software. Then you can collect data prospectively during the follow-up for 5 or 10 years, and then you can also add a lot of information, according to the previous procedure and the previous device implanted on that particular anatomies, already analyze it, and then you can also correlate with the late or midterm outcomes. That could be very interesting for us and for for sure all the physicians involved in this field, in the endovascular repair of the aorta.
So you can upload the CT imaging from follow-up into
Yes.
the CIDR tool.
That is the plan.
Calculates the volume completely.
That is the plan, is to calculate the maximum diameter, and everybody knows that the diameter itself is quite, cool, parameter, and probably it could be much more accurate to calculate the volume, the sac volume, and then you can get better picture about the sac linkage or not during the follow-up. That could be automatic performed by the software. That is an important, could be an important improvement, probably could be available in the next year.
I would really like this feature because, as you say, we're now doing, okay, the maximum diameter is this. We're not looking at completely the sac, and we think the sac is just expanding like this and not expanding like this or whatever.
Yeah.
So this can be a very good tool as well. Any disadvantage for you?
Well, yes, I will say, first of all, for now, the CIDR overlay display on the screen when you're within 60 degrees lateral. And I think a room of improvement is to work up until 90-degree lateral view. I think they work on it too. And also probably a room for improvement is that for now you need to see on the screen 2 consecutive vertebrae, but once you need to catheterize the renal artery, for example, you need to keep these 2 vertebrae on the screen for the overlay to be displayed on the screen. And probably if we can freeze the mask during the cannulation time and reduce the field of view, that would also further help to reduce radiation dose.
Okay, that's a very important top point. So, because sometimes when we do fenestrated or branch cases, and we want to see the ostia of the celiac trunk or the SMA, we're going to do like a 60-degree angulated projection, and then of course we want to put in the blendings, or how do you say it, so we don't normally, if we don't see the vertebrae at that moment, we lose the fusion, or what happens there?
Yes, if you don't see the vertebrae on the screen, you lose the fusion.
So it continuously adapts itself based on two vertebrae.
Exactly, yes.
Does it depend on the height where the vertebrae are, or they just need to see two vertebrae, whatever height they are?
And now it works up until, I think, T8 or T6, from L5 to T8 or T6. It works.
Yeah, that's correct. That's correct. Yeah.
Yeah.
That is one of the limitations for, you know, besides all the limitations we mentioned before, the limitation is about the arch. That is at the moment is not possible to play this with this particular fusion software at the level of the supraortic trunks, and the takeoff of the carotid artery is quite difficult to get it for the same kind of reason, because the acquisition of the overlapping is according to the two vertebrae in the lumbar area, probably T8 and the L5 could be the range, but the people is involved on that particular project are working in order to solve the problem even for thoracic and for the zone 0 up to the zone, you know, descending thoracic aorta too.
Okay, so exciting times are coming up.
Yeah.
On the other note, what do you think? I mean, you have a lot of experience also with other fusion technology. So where do you see advantages of this technology compared to the older ones already existing that come, if you pay for it, with the hybrid room?
Well, in my experience, I would say that the SIDAR fusion with a deformation tool is really reliable throughout the procedure. Even if you move the gantry position and from a lateral view to another one, and if you adjust the mask using the deformation tool in different field of view, it's still reliable and more reliable to me than another fusion, fixed fusion.
Totally agree.
Okay. I have no further questions.
I have a question. I have a question for Dr. Morel about the project you have about the radioprotect study. You start with the study, or just finalize the recruitment, or is in which phase you are now?
It has been granted a few months ago. Okay. So we expect to start the study mid 2023. Well, within the next few months, hopefully.
And you told that in combination with a flat panel C-arm.
Yeah, well, it will be used on mobile C-arm or in a hybrid room, but without the fusion of the hybrid room.
Okay.
And I think its centers that already have the fusion technology in place, the SIDAR technology.
Yeah, only using the SIDAR technology, yes. The 7 centers will have the SIDAR implemented in each centers, and then we'll start the study.
It's going to be very interesting to see those results.
Yeah.
And I hope we will see some results, because as we've seen in those EVAR cases, the more normal cases that there is in every older technology, there is until now not a real reduction in procedure time or contrast medium. But I mean, the biggest important step for us, of course, as endovascular surgeons, is that we reduce the radiation dose, both for us as for our patients. So I think this is already should be enough. If it can show again a reduction in procedure time, contrast medium, this will only be of a bigger advantage. I think the need for it in fenestrated branched cases definitely is there. It helps tremendously. So I'm eager to see the results from the French multi-center trial.
was thinking, as you underline, we're going to check also the surgeon exposure, and we'll check the head, eyes, and under the lead apron. Yeah. For both surgeons and first help.
Are you going to control also which type of radiation protection they are using, like lead shield or like a lead wall with the glass shield, or?
Well, we won't control that. We'll take the information for each center, but they will keep their current practice, and we'll check the exposure of the surgeon.
Okay.
It's a randomized trial, so you know, in both sides you can get more or less better or worse radio protection items, but randomization can help in order to standardize both arms. Yeah.
Exactly, yes.
Okay, perfect. Are you still one last question for fenestrated and branched cases? With the fusion technology, you cannulate your SMA and celiac trunk just with an AP projection, or do you still have the need to get an angulated projection for the cannulation?
If we have a perfect position of the rings we marked before in the map, you can cannulate even in AP projection. And for sure, when you deploy the stent, especially for fenestrated, we need to play with oblique projections, so that means lateral projections, because you need to be sure about the position of the stent and relationship with the fenestration itself, with the ring. But we can play for sure. For fenestrated, we are using to cannulate from below to the top, from Reynolds to the celiac trunk. And if you have a nice map, you can follow the the cannulation without the use of contrast media, less the DCA, for instance, only fluoroscopic shots of iodine, and then mostly we play with AP projection.
We now know. Sorry.
No, I would say I still use a lateral view for SMA and CT cannulation.
Okay. Force technology, you mentioned it before on your first slide, Vincent. Do you think it's again another game changer, or is it still a little bit too difficult? And the second question, can it be combined with this fusion technology or not?
Yes, coming
maybe in the future.
From the last question, yes, the force can be combined with fusion technique even with the sided technology. But force is just at the beginning of the history, so that they need more time in order to develop better, experience. But in the last decade, everything in endovascular is running very fast. So I believe that we can combine force, not for every single cannulation or every single movement in the aorta, but could be a game changer in terms of radiation reduction. I'm totally convinced about it.
Okay, so we have exciting times ahead of us with all the fusion technology that we have and exists already. Any last comment before we conclude, or any last questions before we conclude the session? No, so I want to thank both of you, of course, for your time and your clear presentation. And I think we all get a better understanding of this technology. And of course, a big thank you also to Vascupedia, Cybermedica, and of course also one of you for having this kind of meeting available for us. So enjoy your evening. Have a nice rest of the week. And Vincent, enjoy the last hours of your holiday.
Thank you very much for the opportunity. Bye-bye. Pleasure.
Ciao.
Ciao.